We've been working all day. We got some good results today too. Our recent results have been going well.
Yes, we're at a pretty good rate.
Now, of course, patients are curious about many things regarding the treatment process, the lab, and the clinic. Let's talk about those a bit now so people can satisfy their curiosity. You know, our treatment processes are quite tense for the patients. Expectation anxiety builds up. They get even more tense just because they feel tense.
Because they think they're the only ones going through it. Actually, this is a very natural process. I mean, the IVF process can be stressful for everyone, even for those who seem most relaxed, because it's a situation where you don't know the outcome of the process. Everyone generally experiences it, but the patient thinks they're alone in it.
The inexperienced ones get tense because they don't know. The experienced ones get tense because they've had negative results. In the end, everyone is tense at our place. When does the tension go away? Of course, when they get a positive result. All the troubles.
When the baby arrives.
Exactly. All the troubles and tensions are forgotten. Today there was another patient from out of town. Where was she from?
Oh, right, yeah, Hatay.
Oh, from Hatay. Yes, the patient coming from Hatay. She'd had a few attempts too. You saw how tense she was. People get to a point where they'd cry if you just touch them. Of course, how do we overcome these? First, we overcome them by taking a professional approach. We don't sit down and cry with them. We convince them that these processes can have difficulties, but that all troubled processes can be resolved, explaining it with scientific facts. In this way, we try to help them overcome the psychological difficulties they experience. Because it's very important for them to overcome this. If that woman can't overcome it, she doesn't continue treatment. If she doesn't continue, she can't have a child. They can get into a vicious cycle like that. That's why the woman's motivation is so important. In fact, patients and our nurses, even the new ones, say these are like psychotherapy sessions.
Yes.
So these initial consultations. We think this is very important and we think it's very beneficial.
Absolutely.
Now, there are a lot of topics people are curious about. Is there anything you'd like to ask?
The other day, a patient who had tried in many places came in again. Since she'd found it so difficult, since she'd struggled to conceive, it was her first treatment with us. Thank God she got pregnant, but for example, she was very scared during the examination.
They're wary of vaginal ultrasounds. Patients are apprehensive about vaginal ultrasounds, but actually this concern is misplaced because there's no difference between an abdominal ultrasound and a vaginal one. Neither of them harms the pregnancy. The advantage of a vaginal ultrasound is that because the probe is close to the uterus, it allows us to see the baby more clearly and detect the heartbeat at very early weeks. It doesn't increase the risk of miscarriage. In fact, even for women with bleeding or a risk of miscarriage, we perform the evaluation vaginally. Actually, in medicine, a vaginal examination is what's used to distinguish between an inevitable miscarriage and a threatened one. If the cervix is open, that miscarriage is inevitable and the patient is treated accordingly. If the cervix is closed upon vaginal examination, then it's referred to as a threatened miscarriage. There is a chance that the patient's pregnancy will continue. So actually, a pelvic exam is an important part of the evaluation in cases of threatened miscarriage or vaginal bleeding during pregnancy. Except for very exceptional cases, as doctors, we do not avoid vaginal examinations or ultrasonography during pregnancy. Patients don't need to worry about this point either.
I usually encounter this a lot. Now we go up to the 5th day. We freeze blastocyst embryos. We see a lot of pregnancies even with cavitations at the initial stage. But when we give the patient information about embryo quality, the moment they hear low or medium quality, a perception forms as if an unhealthy child will be born. Either that, or as if it won't take. I encounter these two a lot.
Yes, patients actually need to understand the concept of embryo quality well. We classify embryos according to their formal morphological structure based on the classification made by the European Society of Human Reproduction. This classification is used throughout the world as well. The purpose of using this classification is to predict the probability of embryo implantation. This is a complex classification. We explain it to patients by simplifying it, as you know. In that classification, we naturally expect a high pregnancy rate from what we call high-quality embryos. But just as high-quality embryo doesn't equal pregnancy, it's also possible to achieve pregnancy from medium quality or early embryos, which you call cavitation, classified as 1 or 2 according to the Escher classification. Because the only parameter isn't the shape of the embryo, it's not just the formal morphological quality, the time it takes to reach that morphological structure is important. Genetic competence is important. Is there aneuploidy? Is it a genetically problematic embryo? Those also need to be taken into account. As seen in our experience, the shape of the embryo doesn't guarantee its genetics. The patient's best quality embryos, the patient comes and the ones we trust the least.
Embryos we leave for last in the ranking can turn out healthy.
They can be genetically healthy and they can take. Since we've seen many examples of this, we try to reassure patients in this way. The second concern, as you said, is that one cannot predict whether the child will be diseased by looking at the shape of the embryo. Anyway, genetics cannot be predicted by looking at its shape. Secondly, you cannot understand the pathologies in the organs of the child's morphological structure by looking at the cell cluster either. These concerns are also groundless. Early embryos, or what we call medium quality embryos, do not predict a risk of genetic or formal disease.
It gives us preliminary information about their potential to take. I see that the gap between them isn't very wide anyway. I mean, of course, we prefer to start with the high-quality ones in the ranking, but as we just discussed, we don't know their genetics. Maybe a low-quality embryo can be healthy, and when we take the first one in the ranking, it can be negative, and then the other one can take...
Yes, if we give it a chance. That is, if we see that embryo as having the potential to be frozen, the possibility of pregnancy from all those embryos, because, as you know, we're already quite rigid about that in the clinic. Clinically and in the lab, based on the consensus of doctors and embryologists, we don't store any embryo without pregnancy potential.
We cancel the treatment, but we still don't freeze them. That's why success follows. It's very important. Generally, we try not to prefer the third day. I mean, I've seen it in very few patients in our clinic. We always aim for day 5.
Except for very special cases, we prioritize blastocyst development. Because in a good lab, I believe that if an embryo is euploid and has good potential, it should develop from day 3 to day 5. We maintain our clinical approach by insisting on day 5 embryos. But let's not send the message that transferring embryos on day 3 is wrong.
No, because an embryo that reaches day 5 passes through day 3. When you choose it, of course, a pregnancy can be achieved with it. You can do this on day 2, or you can do it on day 4. But since there's more elimination by day 5, if lab conditions are good, it continues with much higher pregnancy rates.
Yes, and there are cases of day 6 and day 7 embryo transfers in the literature. Of course, sometimes we also wait until day 6 for the embryos. We don't use day 7 much, but there's data about it in the literature too. So it's thought that pregnancy can be achieved with day 6 and day 7 embryos as well. You know, there are embryos that we follow longer and transfer later. The main goal here isn't just for the embryo to wait and mature, but to see if it has potential and can reach the desired phase.
We're actually waiting for it to turn into a blastocyst.
Yes, we're waiting for it to reach the desired quality. To be honest, this is what patients need to understand about quality assessment.
Yes.